Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Howard Meng, an anesthesiologist and pain medicine physician from Sunnybrook Health Sciences Centre in Toronto, Canada, discusses the treatment of traumatic rib fracture pain. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Thank you very much for the introduction, and it's my pleasure to be speaking this morning on acute traumatic rib fracture management. Doctors Dr. Shah and Dr. B, I've known them for a bit, and my roots actually go back to Saskatchewan for high school and undergrad, so it's a nice homecoming in a way, virtually at least, to be joining you guys. I'll be speaking from our experience at Sunnybrook Health Sciences Centre. We are Canada's largest trauma centre. We almost live and breathe rib fractures. We see this quite frequently. Our numbers from an institutional standpoint were probably around 800 rib fractures per year, 200 or so of which are flails, and another 200 or so are of greater than or equal to 5 rib fractures per patient. So we deal with a lot of these, and this is where I'll take you guys through some of the data in the literature surrounding its practice, regional anesthesia management, and some of the next steps that might occur in rib fracture management to kind of further innovate and bridge some of the clinical gaps. And I'll just say that I also don't have any disclosures with regards to this topic to make. This is something that you might have seen maybe 10, 15 years ago, these medical memes that there's a fracture and I need to fix it. This is, when it comes to rib fractures, that's one of the ones that you probably do not need to fix. And so no matter what the, surgical colleagues tell you with the bulk of these fractures, there's really nothing for us to do except to conservatively manage them, which kind of puts in the spotlight it's not a surgical management, it becomes a pain management. And my previous chief of surgery was our trauma chief, really impressed on me kind of the importance of pain management. And I know that, when it comes to anesthesia and pain, pain is often seen as secondary to a lot of kind of disease process. But really in rib fractures, this is where it's front and center to the management of the problem. When you think about rib fractures, they come in all sorts of different ways, but really after trauma, there's about 10% of patients will have rib fractures. If you look at blunt thoracic trauma, the risks of having a rib fracture is essentially 70 to 80%. Most of the ribs tend to occur between the 7th and 10th ribs. And we want to keep in mind that the 4th and 9th ribs generate the most pain because they provide the majority of the chest wall stability. Now, if you think about the different mechanisms, you've got a lot of motor vehicle collisions, you've got elderly with falls. And so the mechanism, the forces by which that's impacted on the chest will vary. So if you look at down below, you get an airbag deployment right through the front of the chest, the sternum, the anterior ribs. The kind of the lateral ribs where there's these buccal fractures will occur. That tends to be where they occur. Obviously, in addition, you'll get the sternal fracture or the manubral fracture that goes along with it. In patients with falls, you're often trying to stabilize yourself. You've got your arm swinging from side to side, trying to keep yourself on balance, but ultimately you end up falling on your side. And so that's where you get the impact on the side of the chest wall there, or potentially along the posterolateral aspect as well. So those are kind of the common patterns of injuries. Obviously, if you're elderly, you're osteoporotic throughout, you may have multiple areas of fracture per rib segment. There's a nice little a few numbers here to keep in mind that when you do get rib injuries, it's not just at the ribs themselves, but rather, all your attachment points, your vertebral body, your transverse process, your sternal fractures. But certainly in my institution, I think we see transverse process fractures a little bit more commonly than 3%. And there are some kind of clinical implications or regional anesthesia implications. We think about that 3% fracture with the transverse process fractures. There's a lot of complications that can occur with rib fractures. We think about essentially, a trauma to the chest with broken ribs that's going to impede your respiratory mechanics. So that's going to be altered, which ultimately impacts your pulmonary toileting, your ability to clear secretions, which puts you at risk for pneumonia. And that's kind of the primary driver of respiratory complications. Further to that, you'll have pulmonary contusions, which will impair gas exchange, have oxygenation issues, may ultimately result in mechanical ventilation as well. So when you consider all these and think about the kind of the injury patterns, you also want to think about the number of ribs that are being fractured, right? It's kind of difficult to fathom that if you had one rib fracture, your mortality rate would be 5.8%. Obviously, the more fractures you have, it increases quite a bit, with 8 rib fractures accounting for about 34% mortality rate. As a single rib fracture, I think it's important to think that, it may just be a minor bump in an elderly patient. I've even had a, work partner in their 40s have a rib fracture just from leaning over in the wrong way. But certainly by the time you get to the 8 rib fractures, we're probably talking about a high energy mechanism with polytrauma. So not just the rib fractures, it's going to be the vertebral bodies, the pelvis, long bones, and potentially even head injury as well. So that accounts for some of the increased mortality that's associated here. And I think that's also one of the biggest challenges about studying this population is that rarely do you just get a patient with a rib fracture. You get a lot of other injuries as well that's difficult to account for. The elderly is definitely one of the at-risk population. And so folks over the age of 65, essentially their mortality rates are doubled. They have more complications in every way possible, whether it's because of the pre-existing comorbidities, decreased physiological reserve. As I mentioned earlier, they're osteoporotic, osteopenic, so essentially they're going to have way more rib fractures. So here's a real patient who's come through our doors. And I just kind of want to set the scene with some of these elderly patients because they are quite frail. This is somebody who came through the emerge, and they're downstairs in the emerge with a right side of rib fractures. You can see that the trauma team has already put in a chest tube right here, and you can also see kind of the kind of opacities that are fairly throughout, at least the right middle, right lower lobe. The patient's on a non-rebreather, and the patient is also a do not resuscitate, do not intubate. And so after the chest tube goes in, there's really essentially very little for the surgical team to do. The rest of it is really on the analgesic management of this patient. And so over the last 10 years or so, there's been these discussions surrounding bundled care pathways for trauma and surgical patients. So essentially the decision points are to make a plan on disposition, pain management, pulmonary hygiene. These are the focal points. And ultimately what we want to get patients to is obviously go home, but that means one, they have to have adequate analgesia in which they're no longer attached to either IV PCA or a regional catheter, nerve catheter of some sort. They can't have a chest tube, and they have to have adequate oxygenation on room air. And so that's the ultimate goal that we're working towards. And the bundle pathway is one of the ways to keep all of us on track. And there's clear evidence to show that the more kind of organized and discrete pathways that we have set up the better the outcomes in terms of ensuring we check off all the boxes on our checklist. One of the ways we score for this or assess for the risks are to use risk scoring systems. As you can see here, there's a few of them out there. I think this is the ribfracture score, the chest trauma score, the rib score. There's the PIC score, which stands for pain, inspiration, and cough. You'll see that they take obviously a few different criteria into account. What's unique about the PIC score, I'll just highlight here, is that it's a dynamic score. So it looks at pain, looks at inspiration, looks at cough, all of which are dynamic in nature and that you can assess them on day zero and going forward. Whereas with the other scores, you'll see that they're contingent on the number of ribs that are broken, the bilateral nature of it or not, or unilateral nature, the age, all of which are going to be static and should not change during their stay in hospital. So that's why a dynamic score might be more favorable, and that's what I would suggest to consider using. So that's the scene for patients with ribfractures. And we'll move on next to a bit about the pain management. The first thing I want to talk about is the types of pain associated with ribfractures. The first, which is nociceptive somatic pain. So just, obviously there's broken bones, which is a nociceptive somatic feature, followed by muscle injury as well. So every time the bones come apart, the intercostal muscles will be stretched and injured. Think about the fact that there's a chest tube that's going in that's going to further disrupt muscle and cause additional injury. These are all sorts of pain that need to be addressed. There's also nociceptive visceral pain, in which, for example, there's lung parenchymal injury, or the chest tube irritating the pleura. These are all potential for causing visceral nociceptive pain. And obviously, we have the intercostal nerves that are part of the neurovascular bundle on the inferior portion of the ribs. If you have a broken bone, you have bleeding, you have trauma to these nerves, you're ultimately going to end up with at least a component of neuropathic pain. So these are the important pains that we want to keep in mind as we come to a plan to address them. Our standard of practice to follow the American College of Surgeons Trauma Quality Program kind of document that was published around 2018 or maybe 2019. To summarize this briefly, essentially it's a multimodal approach to pain management in trauma patients. You'll see that acetaminophen, non-steroidal anti-inflammatories, and opioids, which is our bread and butter for pain management. There's a couple of other notable bits on this. One is that there's no routine rule for gabapentinoids, so specifically pregabalin or gabapentin. And I think that's partly because of the lack of good quality data out there. The last time I looked at this, I think there was one prospective study looking at pregabalin in the trauma patients in which there wasn't any kind of significant benefit. And then a muscle relaxant, so methocarbamol as a routine intervention. Again, there's some criticism of this because there's been one, maybe two prospective studies on this. The difference that they found was that it was a slightly reduced length of stay in hospital with continuous use of methocarbamol. Conceptually, it makes sense to introduce a medication like that because, again, the muscles are injured. There's going to be a muscular component of pain. Even if you didn't have broken rib fractures, a contusion to the chest wall will result in muscle injury. And so therefore addressing that is important. But keep in mind that both gabapentinoids and muscle relaxants, including methocarbamol, can have sedating effects on patients. So in conjunction with opioids and or an already impaired or respiratory mechanics, a potential for traumatic brain injury where the central driver of respiration may be altered as well. This is something that you certainly want to be careful about when giving or prescribing these medications. Ketamine infusion has been one of the things that we use very commonly. Unfortunately, ketamine is also one that does not come with a whole lot of data, or the data has been particularly exciting. Certainly, again, from a mechanistic standpoint, there are some benefits in that it's a non-opioid analgesic. It reduces your risk of respiratory depression. Maybe there's a role in preventing chronic pain associated with rib fractures. But by all kind of critical care society guidelines, here down below, we've got the American Society of Regional Anesthesiologists and American Academy of Pain Medicine recommendations from 2018 on using ketamine for acute pain. I think you can certainly make a recommendation for it, given that it's relatively low risk and the analgesic benefits are there. But from a data standpoint, it's not particularly convincing. Another intervention that's common, I am aware of several centers around the world that use this approach, is to do intravenous lidocaine. In some ways, it's almost like a four-person's version of a regional anesthesia block, but the resources are low. The degree of expertise that's required to implement this is low. You simply need a pump, lidocaine, and tubing to start this process. This is a study done by my colleagues in Western University in London, Ontario, where they did a lidocaine 2 milligrams per kilo bolus followed by 2 milligrams per kilo per hour for 72 to 96 hours. What you'll see here is that rest, the VAS scores are not particularly different when comparing placebo to lidocaine, but with movement that there is a difference in placebo pain scores and a lower lidocaine pain score. Patient satisfaction was also better using the lidocaine. So this is something to consider. I think my colleagues at Stanford had mentioned to me that they actually do serum lidocaine levels, which to my knowledge with our Canadian counterparts, I've not seen this, maybe perhaps due to resource limitations. And then this is a nice review, systematic review by Dr. Delane. Dr. Delane and I, we've had chat before about rib fracture management, and I believe he's out of the University of Alberta. He did a really nice, or his group did a really nice review on the literature on rib fracture pain management. Here's a map of the different comparisons that were made. What you'll see here, there's a lot of the older literature is around the epidural and epidural adjuncts or morphine, whereas the newer studies are looking at the paravertebrals, the serratus plane blocks, the ESPs, and we'll talk a little bit about that as well. But this is a nice summary of the literature that's out there. So I think one of the things that interests us or interests my group is in managing rib fractures is a role for regional anesthesia. Regional anesthesia has a role, regional anesthesia is unique in that it can provide very directed analgesia. When it comes to the chest wall, it's really nice because there's really kind of a specific set of nerves that go to that area. So it makes targeting a lot, at least centralized in a way versus a different, pelvis or elsewhere where you can have multiple different nerve innervations depending on the mechanisms of injury and the source of pain. When it comes to multimodal pain care for trauma patients, it's clear that you'll do systemic opioids, adjuvants, NSAIDs, and non-pharmacological therapy. Regional anesthesia really starts at the beginning of the emergency department visit. It's very difficult to provide regional anesthesia in the pre-hospital setting. And typically they extend all the way up to the point of discharge. And so our regional catheters will keep them in all the way until about a day before they leave or shortly after they remove the chest tube so they can get the most benefit out of it after we've invested the time and the resources to put it in and to run it. The American College of Surgeons document, makes a very kind of a common sense statement saying that the continuous regional anesthesia catheters, instead of a single injection technique, should be used when pain is expected to last beyond 12 hours. And I think we all can expect that fracture pain will last for several days at the very least. And so therefore a continuous regional catheter would be the better option. Now, I do want to point out that I think it was last year or maybe the year before, there was the SABRE trial that was published in JAMA or JAMA surgery, where it was a group of Australian emergency departments where they did the serratus anterior block as a single shot intervention that demonstrated a lot of significant outcomes, including decreased pain, decreased opioid consumption, decreased delirium rates, um, in that 4 to 24 hour time span. So there might be a role for that still if you want to implement that in the emergency department. But for the days following that, I would certainly advocate for a catheter technique. Now, because there's a lot of different types of techniques out there, the associated benefit is from various different regional anesthesia techniques. So reduce delirium, reduce mortality, improve pain, improve respiratory mechanics. These all go hand in hand based on what we've talked about so far. And so that's certainly why we hang our hats on regional anesthesia when it comes to treating patients with rib fractures. The challenge with, again, as I mentioned earlier, is that there's a lot of different techniques. Before the introduction of ultrasound and before the introduction of fascial plane blocks, epidural catheters was kind of the way to go. And so a lot of the comparisons were made to that, but more and more, we've got erector spinae plane block, serratus anterior, and many more that have come out. And the question becomes, which one do we use? So this is a nice little summary by Karim El-Baghdadli, who had previously been a fellow in Toronto. It's gone back to the UK and published this. It's a very nice summary about the different options that are available to us. If you think about the kind of the target for all these different interventions, you've got the thoracic epidural, which targets the epidural space. You've got the erector spinae plane block, just superficial to the transverse process and deep to the erector spinae muscle. You've got the thoracic paravertebral block. You've got intercostal nerve blocks where you go in between the ribs. Serratus anterior plane block. I just learned recently that this is the one that I sometimes do. Didn't realize they gave it a name, but a parascapular subiliocostalis block. So deep to the iliocostalis muscle, and it's parascapular over top of the rib. And so the trend for, like I mentioned earlier, is really to move away from epidurals. There's nothing wrong with epidurals. I still think that they provide amazing analgesia. I'll show you some of the deficiencies with our plain catheters in a moment. But because of the risk of coagulopathy in these trauma patients or the need for anticoagulation, the potential for hypotension with the epidurals, and the risk of infection. Because sometimes we do leave these catheters in for a little longer. For all those reasons, we as an institution, I think also from the literature, there's been a movement away from epidurals altogether for this type of patient. But just as we move towards fascial plane blocks, we also want to be cognizant of the many, many, many different types of blocks that are out there, different fascial planes that has essentially exploded in literature. All I want to say from this slide here is that there's the rhomboid intercostal subserratus plane, serratus anterior plane, pecto serratus plane block. All these guys look the same. It's essentially a rib with muscle, and your target is just over top of the rib. And when it comes to doing these blocks, it's quite nice because the bone is a safe landmark. As long as you can keep it in view and your needle touches on it, that's you can't really cause complications. So don't be overwhelmed by the different types of blocks that are coming out there. Like I said, I was doing one and I wasn't even aware that there was a name for it, simply because I had moved my probe a few centimeters one way. This was a nice scoping review done by my colleagues here at Sunnybrook on looking at the different types of fascial plane blocks for traumatic rib fractures. Essentially, they demonstrated that the ESP and the serratus anterior plane blocks are effective for analgesia and reducing opioid consumption. There's again not a whole lot of comparisons between the fascial plane blocks and the neuroaxial techniques, especially epidurals. And so that's where some of the literature uh, data is missing, and that would probably be helpful for us to make some kind of further decisions with regards which type of block to go with. And so to briefly talk about fascial point blocks as aside we're moving in that direction, the way it works, at least based on what we can gather, is that there are somatic nerves that travel through the fascial planes. And so by flooding this plane with local anesthetic, we'll hopefully capture many of these nerves. There's also sympathetic nerves traveling through the fascial planes. So as I mentioned, that there are pleural irritation or lung parenchymal irritation. That's where the sympathetic nerves would be helpful in trying to address the visceral component of pain. And there's also the nerves to the fascia themselves from both somatic and sympathetic nerves. So as you can think about the muscle planes getting disrupted, the bony planes getting disrupted, this will also cause the fascial planes to be disrupted. And so there could be a source of pain coming from these fascial planes, and therefore, again, depositing local anesthetic in this region would be helpful. This is on the right side is a study looking at ESP block on healthy participants followed with MRI scanning. And so not all of our fascial plane blocks necessarily work in what I've described on the left side. As far as we know with the ESP block, there seems to be spread to the paravertebral space and even to the epidural space. So if I remember correctly, 9 out of 10 patients had this spread to the paravertebral space. So this is the ESP space, this is the paravertebral space. Another 8 actually had it spread to the neuroforamina, and I think 4 went to the epidural space. So there certainly can be different mechanisms of providing analgesia with this, and I'll show you one of our QI studies that we did that might kind of explain or give you a real-time representation of this kind of multi-compartment analgesic effect. One of the drawbacks about the fascial plane blocks is essentially the lack of homogeneous the cutaneous effects. So these are on the left side here. These are patients or sorry, healthy volunteers who had ESP blocks done, and you can see that there's areas of coverage, and then there's areas lacking in coverage, right? And so there must be something physiological, whether it's compartments that are just blocked off. There's some sort of septations, as we learned from the epidurograms, that there are natural septations in the epidural space. There may be some sort of physiological, natural type of barriers that exist that precludes adequate spread, and therefore we get a non-homogeneous type of coverage, at least from the cutaneous, based on cutaneous sensory examination. Similarly, over the abdominal area, where this is obviously in the lower lumbar levels where you're doing these erector spinae injections. Again, based on the type of what appears to be faces drawn in the abdomen, the coverage is fairly inconsistent. And then one of the other drawbacks about the fascial plane blocks is that, one, we're working with large volumes. To have a good area of coverage, especially when considering that there are anterior lateral, posterior, posterolateral rib fractures, it's not necessarily just about covering for one part, it's about covering for the entirety of that chest. And so you need a large volume to cover it. We do know that with fascial plane disruptions, bony injuries, that there's going to be a lot more exposed vessels for vascular uptake. And especially when you think about all the different body parts, with the intercostal area being one of the highest uptake for local anesthetics, this is a perfect storm for having cases of local anesthetic systemic toxicity. So disproportionately in literature, there are way more reports about local anesthetic systemic toxicity when it comes to fascial plane blocks versus any of the other blocks that we do. Some of the other challenges that we have with doing fascial plane blocks is, one, a lot of these patients are polytrauma. So the ability to have their spine cleared and then turn them in a lateral decubitus position can be challenging, often requires another body and requires sedation to accomplish that. There may be disrupted fascial points when it comes to rib fractures, and so therefore the local anesthetic does not spread adequately, and we may get inconsistent or non-homogeneous pain control. We saw that in the healthy volunteers, and the risk is possibly even higher in the rib fracture patients. And then patient characteristics, whether there's obesity, subcutaneous emphysema, and kind of disruption to the soft tissue is nearly guaranteed. The visualization on ultrasound is so much harder, in my opinion, for rib fracture patients compared to any elective patient that you do. I think, excuse me, from the YouTube videos, you might see there's some nice, very nice pictures for, let's say, doing ESP block for breast surgery. You do not see that kind of granularity and that kind of high definition for many of the rib fracture patients. Certainly not all of them, but there's definitely many of them that you have a very hard time seeing. And so I'm just going to run you through a few different kind of catheter videos on of how we do our regional anesthesia catheters for rib fractures. So I think some of you guys are probably fairly familiar with this. This is a view of the thoracic erector spinae muscle. This is the transverse process here, where you have a fairly flat transverse process top, and that's what's going to distinguish it from the lamina, which is sawtooth pattern, or the rib, which is a far more rounded pattern. And you can see here that the needle's coming in here, looking to make contact with the transverse process. The point of contact does make a bit of a difference. Dr. Heejin Chin from Toronto Western Hospital has a series of very nice videos on this, in giving his expert level opinion in terms of where that needle should be. Where we tend to put that needle is right around kind of the top end of the transverse process, mainly because there are ligamentous attachments that attach right over top of the transverse process. Therefore, sometimes it's very difficult to actually create a space or to insert a catheter that's often abutting something and doesn't allow for appropriate thread. And so that's why we target up here, which, it's much easier to split the muscle plane and to thread the catheter. And so this is, us fine tuning our needle and trying to get it at the right angle. This is our next one, where the needle has made contact with the transverse process. You can see that there is a faint hypoechoic layer here from the hydrodissection that we performed. And as I play the video, you'll see that the catheter is slowly threading over across like this, and it'll go in a linear fashion, which is reassuring to us, because our rigid catheters, depending on what kind you have, they can certainly go right through the muscle layer and essentially land deep to this and become almost like an extrapleural catheter. And sometimes the catheter will kind of ricochet up into the muscle layers, and that'll give you essentially intramuscular blockade, which is not going to be helpful in this case. So in all instances, it's much better to have that catheter in the plane rather than intramuscularly. I would rather have that than than to be super accurate with the particular level that we're trying to cover. The plane is far more important. So you'll see here that that catheter, made its way down this way here. And so then what you're going to see here is essentially the catheter being here. There is a faint again, a hypoechoic structure here from the local anesthetic spread. And you can see that plain injection that comes all the way across here. And then this is just fine tuning the visualization of the catheter here. with the pocket of, again, a very linear spread of the local anesthetic. And that's when we know we're happy with the catheter. Now, we can't direct our catheters perfectly well where it sits medial or lateral on the transverse process. It's difficult to say. There is a possibility of it landing retrolaminarly. There's also a chance that it migrates laterally because of some fascial plane disruption and lands on the rib. And so this is something of a different set of catheters I did, not for rib fractures, but just on a fairly obese patient. And you can see that, again, we're trying to fine tune our angle here. Our needle tip is coming down to contact bone. In this view here, we've got more rounded ribs, and so it's not a true ESP. But again, getting into that fascial plane is more important, and having appropriate visualization is important. So I'm not as fixated on getting it right onto the transverse process if it's not safe or I don't have a good view. This next one here is, again, me dissecting this plane. You've got again, it's very nice and linear, which is reassuring. Obviously, we've got injectate backing up into the muscle or going deep to the point between the top of the ribs here. Then that would suggest that you're not certainly not in the erector spinae plane. So again, here's the video one more time. We're just opening up that space to insert the catheter. So this is one of the challenges where there are fascial disruptions or physiologic ligamentous attachments that precludes your catheter from having the perfect position. What you can see here is that this catheter is being advanced. And I don't know if you just saw that, but there's a very subtle tip kind of bouncing up. Now, if you have a very firm catheter, it'll just go right up into muscle. And I'll play it again. It makes a jump right there because I just could not feed it through. There's something attaching here that's abutting it. And so here is where I fine-tuned it. That catheter is once again linear, and there's a hypoechoic kind of local anesthetic spread over top from one bony part rib here to another, which would indicate, at least sonographically, we're in a good space, and we'll likely have a good outcome with the analgesic effect. Now, this is something I've done just to check the location of the catheter. This is not part of our routine care. What you'll see here is essentially the catheter running this way. I've put a bit of contrast in. I've taken a portable X-ray just to see where that tip is. Just for landmarking here, these are the pedicles on one side of the chest. Here are the transverse processes. And so what you'll see here, this contrast spread is right between the pedicle and the transverse process, or on the transverse process, which would suggest that we're in the right, at least from a medial lateral standpoint, being on the transverse process in the erector spine plane. And then here's a video of what the patient might feel like after the injection. One of the challenges about these fascial plane blocks is that we don't have a reliable way of testing the success of these blocks. As you saw previously, the cutaneous innervation or the outcomes are highly variable. It's not homogeneous. There's no temperature difference. You can't check for that. And so my crude way of doing it is essentially gently tapping them over the chest and see how they respond. And as you can see here, this is a patient who had a catheter put in, and it was a gentle tap over the chest. They had very little to no reaction to that. And so we do know that these catheters work very well for patients with rib fractures. And so over the next bit, I'll talk about the Sunnybrook experience, our kind of how we run our rib fracture management protocols and how our team kind of works together to deliver this type of care. So our pain team involves kind of two separate groups. One is an acute pain service physician with, we have three full-time nurse practitioners at our Bayview campus, which is our trauma site. And this group they're responsible for rounding on in the emerge, the ward, and the ICU. And I put emerge down here because it's important that we focus on timely care. I'll bring up a slide in a bit about kind of when we should have our regional anesthesia catheters in to reduce complication rates. And so intervention at the emergency department level, I would consider that to be key to effectively managing these patients. In the block room, we've got a regional anesthesiologist, anesthesia assistant. 95% of the time, we've got an anesthesia fellow in the room. And then we've got a separate block room to manage these patients. So here's our block room just outside of the OR. We've got 3 block bays. And again, we're assisted by anesthesia assistants in this room. We bring patients from the emerge and from the ward to this room to do the blocks. Patients from the ICU, we typically leave them there because of transfer challenges, monitoring challenges, and it's just safer for the patients for us to do there. So in fact, we take our ultrasound or our block equipment and go to the ICU to do that. The way we've sorted out our analgesic pathway is to have a rib fracture analgesia order set. So this is actually initiated by the trauma service when they see the patients in emerge. And so it's essentially a checklist of consultations, referrals, pulmonary hygiene maneuvers, mobilization orders, as well as straightforward acetaminophen, non-steroidal anti-inflammatories, opioids. More often than not, they'll initiate low-dose ketamine at 0.1 milligrams per kilo per hour. Where APS becomes involved by our policy is that if they're going to the ICU, and obviously any of our frail patients, elderly patients, patients with FVCs less than 1 liter or 30% of expected would end up there. If you've got chronic opioid use, substance use, if they have inadequate pain control after being admitted to hospital for 12 hours, that's an APS consultation. And so the APS team would consider them for regional anesthesia catheters, titration ketamine infusion, additionally antineuropathic medications, whether it's gabapentin, pregabalin, or the addition of muscle relaxants in the form of methocarbamol or cyclobenzaprine. I would say that the majority of the patients seen by APS will have their pain well managed, at least with respect to the rib fractures. Very few patients will then go on to have surgical fixation. So if you have an open injury, persistent pain after APS intervention, or if they have had prolonged mechanical ventilation. Rib fixation is something that's done fairly commonly in the US. It's not done as commonly here in Canada. There's some evidence, prospective evidence to indicate that you can get patients out of hospital sooner with surgical fixation in a specific surgical subset. But again, when it comes to overall patient numbers, they're of a smaller number. Timing, with regards to timing of intervention, so as I mentioned earlier, we round on patients in the emergency department to intervene on these patients as soon as possible. This is a retrospective study done, published in 2022, looking at the initiation of ESP blocks in around 200 patients. What you'll see here, and this is there's several different time points. One is the late block, so after 48 hours, less than 48 hours, or between 24 and 48 hours, and then this is less than 24 hours, which is a prompt block. You'll see that the orange here is respiratory failure in patients. At least what they've demonstrated here is a 0% respiratory failure done within 24 hours, likely because the patients that respiratorily failed probably didn't get a block to begin with, and they were intubated and went to the ICU. But it does speak to the fact that the earlier you do this, typically the better the outcome. So we've always targeted less than 24 hours and less than 36 hours. As you can see, there does require a bit of assistance, clinical expertise, technical expertise, and resources to put all this together. So it's not necessarily feasible to implement this overnight, especially when there are other emergencies coming through to the operating rooms. This is a quality improvement project that we did, and we published an REPM a couple of years ago, looking at patient-reported outcomes following a ESP block or ESP catheter. You'll see that with regards to ease of breathing and ease of coughing, there's a significant increase from before to after. And there's a subsequent increase at the 1 day mark as well. And this is both for coughing and breathing. And this might speak to the fact that it takes some time for the local anesthetic to spread through the different compartments, as we saw from the MRI study for the healthy volunteers, that it does spread to the paravertebral space, the neuroframe, and the epidural space. And we use an intermittent bolus program, and so that every couple of hours we instill another 10 to 15 cc's of local anesthetic in this compartment, and hopefully over time it provides a bigger and bigger area of coverage and denser area of coverage. And that's what probably explains for this increase in uh, uh, I guess patient benefit. So going back to our patient from the emergency department, this is that 90-plus-year-old patient who was on a non-rebreather with pulmonary contusions, a chest tube, who's not for intubation and who's for purely analgesic management. And so I went down there and I put in a serratus anterior catheter because his spines were also not cleared, so I couldn't turn him over and do an ESP. Gave him a large bolus. And when I returned from, I think I went on vacation, but when I returned, I followed up on him, and this was him about a month and a half after discharge from hospital. Chest is relatively clear. I think there's some scarring over the lungs here and whatnot, but the outcome was there. We were able to help, you know, have a good outcome in this case, and I think it speaks to the kind of the possibilities of what we can do with regional anesthesia, as well as early intervention in a high risk group of patients. We also get a lot of patient calls from the ICU about patients who are mechanically ventilated and sedated. We are a regional trauma center, so we get a lot of patients who come through to our site who are already intubated from the peripheral hospital. They come here after a few days. The ICU asks us, can you do something for us? And it's hard to have that pain assessment on a patient who's not giving us any feedback. But it's a large population that we deal with. It's probably about 150 to 200 patients per year that fall into that category for us. This is a prospective study done by a French group, I believe, looking at using ESP early on for these polytrauma patients. And unfortunately, they couldn't find any differences in terms of the degree of sedation, which is over on this side by midazolam, comparing control, and CRA, which is continuous regional anesthesia, uh, as well as the sufentanil. So the analgesic consumption is no different. We subsequently, so our group here at Sunnybrook, we did a small retrospective review of our population, looking at what they call CRA, continuous regional anesthesia infusion in these mechanically ventilated patients with acute traumatic rib fractures. We just published this recently. And it looks at patients who've been in the ICU who've either received an acute pain service consult versus a regional anesthesia catheter. What we see differently in our retrospective study is that there's a significant drop in opioid consumption here compared to with continuous regional anesthesia catheter, compared to patients who did not, who just received oral or intravenous analgesics. The difference here is that we actually looked at our group about, on average, 4 to 5 days out from their time of presentation to hospital, whereas the French group had done it right off the bat, looking at the first few days. And part of our speculation is that these patients often are coming in as polytrauma over the first few days. They're getting other injuries fixed. Perhaps it's an ORIF, perhaps it's an X fix, wound washouts, things like that, that will have a significant opioid consumption to these procedures. And it's not only until that those problems have been addressed are we able to see the difference with these regional catheters when it comes to the chest. And so I've gone through what we currently do in our ribfracture management pathways, but there's a bit more room, for us to do better. One of the things that we've done very well is the degree of analgesia we've been able to provide. And I think when it comes to multimodal oral analgesics, the occasional IV delivery, regional anesthesia catheters, and the IV, refers to ketamine or lidocaine. And this is on top of our regional anesthesia catheters. Patients are fairly comfortable. The downside is they're obviously attached to our hospital devices. They're attached to our care. And that is an area where we can try to save on resources and commitment. And so the duration of analgesia is limited by the catheter being in situ, and the length of hospital stay we have not made significant differences to. So the question becomes, what if we can prolong pain relief and still get patients discharged sooner? And I think the challenges that we face here locally, which is hospital beds, is probably no different than what we see across the country. Just want to put it out there that I don't have any particular affiliation with this device company, but this is a picture I took from their site. Essentially, this is a bridging of kind of chronic pain practice with acute pain practice. We're trying to make an intentional nerve injury or intentional nerve injury to the intercostal nerves. And that's, again, one of the nice things about managing rib fractures is that the innervation is fairly simple. The idea is that we can put this needle tip adjacent to the nerve. A needle tip here makes an ice ball, and that ice ball goes adjacent to the nerve. We're going to minus 88 degrees. We're creating a intentional lesion to the nerve. In this case, the product monograph indicates that it's Sunderland 2 level type of injury, and so there is room for regeneration of the axon slowly, and so that's where the expectation of this providing longer term pain relief would come in. And so the idea is that you've got your needle, you're making an ice ball, and you're making that ice ball right around adjacent to where the nerves are passing through. Sonographically, it would look like putting that needle right underneath in the area of the neurovascular bundle on the caudate side of the rib. There's been a handful of studies that have come out for this case series. I believe a Stanford group even used CT-guided approach to do this, which is a luxury to have that kind of resources dedicated to it. But to my knowledge, there's no published a randomized control trial on this. My group here at Sunnybrook, we do have a RCT, a pilot RCT on doing this using a percutaneous approach to cryoneurolysis of the intercostal nerve and acute traumatic rib fractures. And we're just at the end of our enrollment here, so we're hoping to have that published next year. But again, the goal here with the cryoneurolysis is to get patients under control better and get them home faster. And I'm aware of a few centers in the US that are using this, just offering cryoneurolysis as an option over regional anesthesia catheters. They're using it as one versus the other. And then finally, one of the exciting things that we're working on here at Sunnybrook again is looking at a population-based cohort study. It's a RAF study by my colleague Naheed Jivraj, who's in both anesthesia and critical care. We see a lot of variability in terms of delivery of analgesia for rib fractures at Sunnybrook and across Ontario. And so this is a large ICES study to look at how care is provided across the province. We want to see whether the use of regional anesthesia catheters result in kind of reductions in complications or some of our key performance indicators. And then ultimately, we want to use this data to implement some local as well as potentially provincial and national policies or guidelines to direct the care in this group of patients. So coming to an end here, just wanted to, offer some of the important messages here, which is rib fractures are associated with high morbidity and mortality. The elderly, in particular, are at very high risk, and so a lot of our attention should be directed at that. Effective pain management is a priority. Apart from inserting a chest tube and/or in the select few that do get rib fixation for surgery, the rest of it is really, we are front and center as part of that solution. And so it's important that we, develop protocols and ensure that our services are aligned to address this. Regional anesthesia catheters are the gold standard of care. We've had fantastic outcomes with our catheters, as you saw from our quality improvement bits, the patient satisfaction rates, the ability to cough, pain control. It's quite high. And I think over the next 5-10 years, with introductions of additional technologies that, especially handheld devices where we can offer novel treatments, that may be a game changer in terms of where rib fracture pain care goes. But that's something that we'll have to wait and see.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.